kind of thing, and somebody said that to you? Would that make you calm down and stop screaming so that you could get care? Or would that make you more anxious and do it more? Because you felt like somebody wasn't going to take care of your need.
Yeah, that pretty much made the situation worse. Call lights. Just remember to leave the call light on until the need is met. That need should be met within 7 to 10 minutes at maximum. If you're at the nurse's station, the call light can be answered through the phone system. This is underutilized, so it is a way, especially for charge nurses, to be able to find out if there's something that needs immediate attention, or if maybe it can wait. Maybe somebody just says, "I'm just wondering what time my shower is today."
Well, they need to show us how to use it, because the last time I asked when they were putting the new, whatever that one to open the door, we weren't using that. There was some reason why we weren't using it, so I don't think anybody knows what to do or how to
We can
do
show
it.
you.
Yeah.
We can show you. 66% of the time that a call light rings, it's a need that anyone can answer. Anyone from a housekeeper to maintenance to me walking by. 66% of the time, it's something like they dropped their remote, or could somebody change the channel? It's not necessarily something that nursing has to address. Good phone etiquette should be used every time we answer the phone. The nurse on hall 1 carries the phone, except for on MCU, where there's only one nurse, and is expected to answer it. We get a lot of complaints about phones ringing and nobody answering them. And just think about what that is like to a family member who is trying to reach their loved one, especially if it's a time when they can't visit. You should identify yourself when you answer the phone. You should say your name so they know who they're talking to. Personal business and feelings. So recently we had conversations with several residents, but especially the sisters, and some of the comments they made were that they know who's mad at who's thinking about leaving and going to agency, who can't get a babysitter, who's getting divorced. All that stuff should never be talked about in front of the residents. And one resident in particular told me that if two people come into the room, they only talk to each other, they don't talk to the resident. So they kind of make that person feel like they're non-existent. So just remember to keep personal stuff at home, or at least not discuss it in front of the residents. Providing care and documenting. So resident care is provided per standard of care, and documentation must be done every time you work before the end of your shift. If you're unable to get into POC, let the unit manager or nursing supervisor know as soon as possible before the end of your shift so we can get that addressed and taken care of. I know that sometimes with agency, it has happened that we don't get somebody in to point care immediately, and then we find out that somebody has worked 3 times and they don't have a login. I mean, how are we documenting, right? So if you know of an agency person who isn't documenting, let us know, because it's possible somebody slipped through. Yeah.
I have one. His name is Dave. I don't know his last name, but he's not able to document.
Dave?
Yeah.
Okay.
He's from agency.
Okay. Has he worked recently?
Night shift?
Yeah.
Okay.
Okay, we'll figure out who it
Okay.
is. Okay. Completion of documentation is poor and inconsistent, so just a reminder to make sure you guys are doing your documentation, especially the POC documentation for STNAs. It's monitored by Peggy, and notifications are sent to the unit managers, and we follow up on that. Remember that this does affect our reimbursement. It depends on documentation, and that's why it's so important. Nurses are also expected to check your documentation, check the STNA documentation prior to the end of the shift, and make sure that you are nursing, make sure that you're asking STNAs if they've completed their documentation. It's very important. Huddles, we've talked about this, I think, every meeting. They're to be done every shift, at the beginning of the shift. STNAs, you should be turning in, and nursing, you should be turning in that huddle sheet at the end of your shift. So please make sure you're doing that. I know it's easy to think if you work every single day, that nothing has changed in the last 24 hours, but that's not always the case. Somebody could be on a different diet or could transfer differently. Okay, a few things about teamwork. Every time we interview STNAs or nurses, they ask how the teamwork is. I mentioned that earlier. And, you know, we want to always say that the teamwork is good. In general, it is. But just think about, I mean, Sue already talked about all the challenges we've been having the last year and a half. And sometimes staffing is a little bit tight. But if we work at a team, it's always going to be better. If we want new staff to stay, we need to keep conversations positive and be helpful. That's pretty obvious. If we want staff to stay, good teamwork on the floor is important. If we want staff to stay, we have to attempt to develop professional relationships with them. People stay at a job because of the people they work with. That's the reason people stay. More so than even the job they're doing, it's the people they work with. So we want people to feel comfortable with each other. Some of the comments we've gotten from STNAs and nurses that have left is that there's no teamwork and that all they hear is complaining and people being rude to each other. And again, this goes back to our mission and making sure that we're following the mission with each other, not just the residents. We also hear great things, so I don't want to not say that. We hear great things about certain people. And so we appreciate that. Okay, victories. Part of Clare Hall is reopened and we've joined it to CCU temporarily. Sue touched on that, so assignments have shifted to reflect this. Two of the STNAs, JAM and M&M, helped us rework the assignment, so we appreciated that. We do listen to your input, guys. So Tiffany, I want you to, I know you mentioned earlier, how can we help you guys on the floor? So I really hope you come up with some ideas and we will listen. Okay?
And the other thing I just want to say too is listen to each other too. Like, you know, sometimes, well, I'm not going to listen to you, Tiffany, because you're telling me what to do. Well, that doesn't set anyone up. And, you know, like, I'll give you an example, and I know it's kind of silly, but my daughter came home, she does competitive cheer, and she's on the senior level team. She's 12. There's kids that are 18 and 19 on her team. So it's a really wide range of ages. And she's got one girl that, because she's older, she thinks like she knows, even though my daughter's been cheering for like 7 years now, and she's only been cheering for a couple years. And my daughter is a flyer, they put her up in the air, she knows how her feet need to be held, and stuff that I don't know, but she knows that because she's been doing that. So she came home and she said, Mom, so-and-so's not listening to me. She always argues with me, blah, 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 blah. And one of the things I said to her, I said, Reese, you're both not right and you're both not wrong. So why don't you try the approach, hey, let's do it your way this time, and then next time when we do the same stunt, can we try it my way, and then we'll see which way is better. So both people feel listened to, they can try it out. Maybe there's good things from both of their points of view, they can combine and then they're good to go. Like, I just think we need to sometimes take that step back and say, okay, you can't always be wrong, Tiffany, and Sinead, you can't always be right. So how can we work together to get this accomplished? And I get it's frustrating. I mean, you guys, I know are frustrated, but no, too, sometimes we're frustrated. You know, not at you, but just by the situation. You know, we're in the same place. We want to make it better for you guys, but we got to take that step back and say, okay, I can't let that out because that sets the tone. How do we all work together so at the end of the day we get everyone's job done? We get the residents taken care of, and that means Barb's able to get them showers and do restorative and do the things she needs to do. Tiffany, you're able to do the meds and the treatments and your documentation, and you got appointments scheduled, and in the end we all feel good about what we did, because I know there's days we don't feel good about
our days been like?
We are hiring. I think you all know, hopefully now.
That's a shocker, right?
Yeah. Orientation today is one of the biggest we've had in a long time. I think it's 13 or 14.
Oh, wow.
I think we have 5 nurses.
Fingers crossed, everyone. Fingers crossed.
I think we have 5 nurses, a number of STNAs, and some care attendants. So we are trying. I want you guys to know that you've all gotten texts from me saying, "How would you like to pick up on Friday?" And we tread the line between harassing you and just trying to help out on the floor. So know that when we go into a weekend and we have 3 or 4 holes in the weekend, I'm texting people. Sherry is, Steve is, Mike is, Peggy is. Sometimes we even get Sue involved in that because we think they might listen to her more than us.
No,
But we understand, and we are always trying to fill those spots if there's one open.
I have a question. How are you guys with the hiring process, working with the challenges like with STNAs? Like I just saw somebody was hiring CNAs, $30 an hour. So how are you being competitive? Because I know that's really like one of the biggest where everybody is going. I mean, the amount of money that's being thrown to STNAs and nurses right now, I mean, who wouldn't go get it? I know you guys can't put out that kind of money. So outside of the bonuses that you guys offer, like how are you guys drawing them in to make them even for that?
So we do have a hiring bonus that we're doing, and here's my thing. I never want to take away stuff from you guys. Like, there is no way a facility is going to be able to maintain $30 an hour for an STNA. Because if I'm paying an STNA $30 an hour, I'm paying an LPN $40 an hour, and I'm paying an RN, even more, and then I'm paying administrative nurses more. Like it just, and I have to pay housekeepers more. It's across the board at that point, and you can't sustain that unless you have no staff and you're the only STNA on the floor for $30 an hour. So, that is a balance. We've always tried to staff better than everyone else, but you can't do that and pay less either, or at the 100 percentile. Everything's on a scale. We're not going to be down here in the lower 25th, but we can't be up here and staff high too. So there's got to be, some changes. We're looking at different things, and I'll be honest with you guys, med techs. Can we substitute with med techs, which relieves some of the nursing things, to do documentation and deal with families and other things? How would that fit in? If we got a unit secretary, or the hospitals sometimes use helping hands or volunteers that can do water pictures and, some of those things that aren't nursing related things. How does that fit into a staffing model on the floor? So we are looking at, it's not an easy thing to do overnight because you got to look at how many people do you have on the floor, what does everyone make, and ultimately still fit it into your puzzle of there's the dollars that we have to deal with. But those are some of the things that behind the scenes that we're doing. And sometimes I do pull the unit managers off and you don't see them because I'm like, okay, we are sitting down, we're brainstorming, we're coming up with different options. So all those things are in the works, but they're not immediate. On the med tech thing, we haven't pulled that trigger yet because there's not many med tech programs out there. So if we hire and we go that route, I need to be able to provide you a med tech every single shift or the shifts we designated on 7 days a week. And what happens if I can't? What's our backup plan then? What do we do? Somebody calls off, like we're not going to have a whole bullpen of med techs. So those are some of the things that we're thinking about, that we do pros and cons on, that, so if you have ideas or you've seen things at other places, let us know. And like I said, I don't want to put $30 out there and then in a year when the market changes say, oh, sorry, you're not going to make $30 an hour anymore. Now you're going back to 15 or 16. Because I just don't believe that's the right thing to do. I think, you know, we need to look at our budget, we need to support and do what we can. But in doing that, it's just not labor that's gone up. You know, some days we can't get canned green beans for God's sakes. You know, and then we have mad residents because the menu says green beans and we tried to get green beans 2 weeks ago and there's no green beans to be found. And I know that sounds silly, but it all goes into the end experience for a resident, and you guys are the ones hearing that there's no darn green beans for the last week. You know, like, I mean, we get those things, but green beans cost twice as, what, I saw $5 a pound for turkey from one of the small markets. I mean, like, that's insane. They did a price comparison. The turkey that used to cost like $28 is now like $55. You know, so you can't, as you guys know at home, you can't have a budget that everything goes up astronomically and at the end of the day, still be in business with keeping things the same. So that's where I'm saying, if you have ideas, and I know you have something that you want to share.
My sister's a DON, and she had a group of home health people who became medical certified through her.
Okay.
And that might be an option. If you
With the
get
med
someone
techs.
instructed, you be certified, you could help them in some of the situations that they're in. It would be maybe an added tool.
Yeah.
And those that wanted to take the class could. And then if it was a pinch, you could. You know what I'm saying?
Yeah.
So that's, I mean, I'm just saying that's what they did because they go into the home and they have to give medications and do insulin and all that kind of thing. So it's quite a certification you get when you do get a medical certification.
Not done yet. We're almost done.
So
yeah.
that's just an option I thought, you know, I mentioned because.
Yeah, and like I said, we're willing, like, in this market, everything we
Because I see it
know.
across the board, so I
Yeah,
don't know how anybody else is staying.
And that's what I'm worried about. As
That's
an
where I'm at.
administrator, and I don't just talk nursing home administrator, but in healthcare administration, I'm worried that our healthcare system is going to collapse as we know it. It will not be the same. It will not come out. You will not be able to get the appointments when you want them and get all the services that you have access today if this continues. It's just not going to be sustainable.
I called to make an appointment for one of the patients to see a nephrologist through UH. Every specialty doctor through UH is completely booked through January already.
Guess why? Because people don't want to work, or they're changing their hours and saying, sorry.
I was like, what if it was like a dire emergency? What if it was something that needed to be met, like, you got to wait all the way to January 26th?
No, guess where you're going to be in the
Yeah.
hospital is where you're going to be,
Yeah.
unfortunately. Which is not a good use of our healthcare dollars either. You know, I mean, it just creates a vicious cycle because then that hospitalization costs more, it puts strain on the hospital. I mean, it's just a big trickle down effect. And that was my point before, is like, we gotta be thinking about those things because I do fear, and not just for nursing homes, that our healthcare, we are going to collapse healthcare as we know it. You want what Canada has, where you gotta wait for 6 months to see a doctor or dentist.
Even
Here we come.
the tumor removed or
Mhm.
that's what Canada does.
Yeah, I mean, years ago, we were doing a program with a clinic where we had people coming to Marymount Place to stay after bone marrow transplants because the waits in Canada were so long. And they had, you know, done a deal with the clinic. So, anyway, but if you have ideas, we're willing to listen. If you have a small group that you want to get together and do a discussion, you know, like Mark and Peggy will sit down with you, or Mike, or whoever your unit manager is, I'm willing to sit down with you guys, but I want us to be productive. That's the only thing I ask. If you bring a problem, bring some ideas. Because I can't just fix 100 complaints. If that makes sense.
Right. The only thing I want to say on that is this morning I saw a commercial for Aldi, 88 cents a pound for turkey.
Oh, there you go. And this was a small market, so I think it was probably an organic turkey, but still, I mean, that's crazy for a turkey.
So just a couple of other victories, guys. We just hired 2 new MDS nurses, I believe, so make sure that we welcome them. Out of outbreak, do I just want?
Yeah.
Okay. Out of outbreak, we talked about visitation and the do's and don'ts and the PPE, so I won't repeat that. We have new beds that are going, we're replacing all of our beds with new beds that have the ability to go all the way to the floor and to lengthen, so that is going to be a huge help. So the day will come
Because
soon.
we're getting bigger people.
Right.
Not this way, but
Yeah.
this way.
Exactly. So the day will come, hopefully, when we're not ordering any beds from Advocare, or minimal.
So,
And you got new climbers too, I saw.
So this is a prime example. You can come in, we're almost done, Val. The beds thing is a prime example. We heard staff say it takes a lot of time to call, to be on the phone with Advocare, to get the bed. They don't send us the right thing, then we have to call them back. And we swap them out, and we're moving people, this, that, and the other thing. We have to wait for them to move a bed. You know, if we're moving rooms, that happened a lot with quarantine and whatever. So we knew we needed new beds, and one of the things that Bill did a very good job is get a sample of a bed that went wide, that went long, that had heavy, that went almost all the way to the floor, that we could get a mat with, and that's the bed we chose to try to get rid of some of that other stuff. So that's what I'm saying, if there's equipment or things like that that we can help with, we are opening to listening, and we probably paid more for the beds than we would have normally bought a bed for, but it decreases rental costs and it decreases staff time on dealing with all of that at the end of the day.
Appointments and visits, making sure that patients are dressed appropriately, toileted, and ready to go prior to their pickup time. We had a situation a couple of days ago where somebody went out. Remember, it's winter now. Make sure that, and they may not have a coat, but we need to make them as warm as possible when they're going out. So even if we have to put them in blankets, but making sure people are dressed appropriately when they go to appointments is important. It's all of our job to enforce the visitor rules. No one should be visiting in the common area. No families are to be eating with residents. Just refer to the rule sheets. And again, that's touching on something Sue mentioned earlier. They can bring food in for their loved one. They just can't eat with them. STMAs, thank you guys. You do not have to stay for this part, just the nurses for a few more slides,
I'm
okay?
so glad I got to work tonight.
Just a couple.
I gotta go home and sleep.
Okay, so nurses, medications and treatments are expected to be delivered per physician order, and EMAR and ETAR are expected to be signed off after med is administered or the treatment is performed. That's something I think we go over every meeting. Narcotic counts are expected to be completed appropriately, with both nurses looking at count sheet and card to make sure they match. Often we see the oncoming nurse going through the cards and the offgoing nurse reading what is in the binder. That is not the way to do it. You both need to be making sure.
I can tell you anything, and you're signing off.
Yeah. And especially think about that oncoming nurse, because you are now accepting responsibility for whatever just happened there. Okay. Narcotic controlled substance count sheet is to be signed off when you take a medication from the locked drawer on the med cart, and then